in the chat, but I wanted to get started because we have so much that we want to and need to get through for today. And so I want to make sure that we start on time so we can give our speakers and give us plenty of time for discussion. So again, I want to welcome you to the Washington Healthcare Facilities Community of Practice Initiative. We're so very glad to have you join us today for our session entitled, Is It Clean? Lessons Learned on Improving Environmental Cleaning in Healthcare Facilities. I want to introduce myself today and our team. I'm Joanne McGriff, Assistant Professor within the Department of Global Health within the Rollins School of Public Health at Emory University and core faculty within the Center for Global Safe WASH at Emory. I have with me our learning team, which includes Lindsay Denny from UNICEF New York, Haley Elling from World Vision, as well as Emily Schoendorf, who is a current grad student working on Washington Healthcare Facilities with us here at Emory, soon to be a formal graduate of Rollins. We also have several members of our Community of Practice Steering Committee present in the virtual audience somewhere, as well as one who hopefully will be able to join us and serve as one of our presenters today from WaterAid Cambodia. So we're very fortunate to welcome several other speakers and panelists from other organizations, partner organizations like Molly Patrick from the CDC, Dr. Adeni from the Center for Infection Control and Patient Safety at the College of Medicine in the University of Lagos, Nigeria, Dr. Wendy Graham, as well as Dr. Georgia Gahn from the London School of Hygiene and Tropical Medicine. And we've gathered these speakers to come and talk about the issue of environmental cleaning as a critical component of quality care in healthcare facilities. We'll have the benefit of hearing about specific toolkits, strategies, packages that are useful to us and could be useful to you all as implementers, researchers, and others when it comes to approaching environmental cleaning, and then have some opportunity to hear actual case examples of how these tools are being used in specific contexts. So we're really excited to hear from our participants. And so I'm just going to go ahead and move to the next slide and get through some of our business. We are also fortunate to have as part of our team a great group of interpreters who are assisting us today with Spanish and French speaking participants. So in fact, if you haven't already, I'm going to go ahead and ask you to choose your language of choice in the bottom toolbar. We're asking even participants who are listening English, go ahead and just make sure you choose English, just so that we make sure you're plugged into the language that is most preferable to you. Next slide. Before we launch into our session, I want to take a few minutes to welcome new participants to the Community of Practice and tell you a bit about what we do and who we are. We are an action-oriented learning platform that brings together the WASH and health communities to focus on policy, evidence, and practice in WASH and healthcare facilities. Our goal is to connect the expertise and experience of our partners and colleagues to the members of the WASH and health community who have expressed interest in moving or taking action in WASH and healthcare facilities. We've created this platform as well as our newsletter, our webpage to share resources with the WASH and health community. And our goal for each live session is that participants walk away with some tangible information and opportunities to really take almost immediate steps to advance the improvement of WASH and healthcare facilities. So next slide. Want to remind everyone of the guiding principles of this community of practice so you know where we're coming from, what is our position as it relates to these webinars or when you see our newsletter. And so we believe in the first bullet here that WASH is a fundamental prerequisite for quality care within a healthcare facility and that there can be no effective infection prevention and control without adequate WASH. We also believe that the issues that we have going on in WASH and healthcare facilities are solvable, but it will require multiple systems, sectors, stakeholders to work together to see sustainable improvements. And in this community of practice, we want to know that everyone is welcome. We're open to all who seek to learn and do more in Washington healthcare facilities, as well as share our best practices, our experiences. And so whether you are a seasoned expert in Washington healthcare facilities or WASH, or someone for whom this topic is new, we welcome and appreciate your participation. So on to some news. So each time we come together, we want to provide you with updates on resources or research that can inform and enhance your planning or your current work in Washington healthcare facilities. So for this month, and especially given our topic, we wanted to highlight that earlier in March, the WHO released the Environmental Cleaning and Infection Prevention and Control in Healthcare Facilities in LMIC's Trainer's Guide, as well as learning modules and resources. This is a training program for cleaners. This resource was developed on the basis of the Teach Clean training package developed by members of the London School, who we'll be hearing from today. Again, this resource can be used by those who generally deliver or plan to deliver environmental cleaning training to cleaners. And the goal of the two-part training package is to improve the competency of healthcare facility cleaners through a hands-on practical approach to adult learning. So if you've not, please take a look at the WHO website that have the PDFs that can be downloaded, and you can review it when you have an opportunity. Next up is our Success Corner. Again, this is a place where we highlight good news that's happening in Washington healthcare facilities. This month, as we're in the final days of Women's Month, we highlight the White Ribbon Alliance and their groundbreaking What Women Want campaign that has given us all really so much insight into how highly women prioritize WASH, and specifically WASH in healthcare facilities, within their understanding and within their prioritization of what is what they want. A lot of the data that was collected has been used for good purpose, and what we have here is some news from Nigeria, where as a result of the campaign, many communities raised their voices in local health committees, town hall meetings, lots of policy dialogues went on as a result of just seeing this information come forth so very clearly. And as a result, Niger State Public Health, Niger State Public Health funds were used for the first time ever to support structural improvements and WASH upgrades in 39 primary healthcare facilities. Like, that is a win for all of us. So we would hope that data like this, hearing the voices of women, would really be what our policymakers are considering when it comes to making change. And so this was really an exciting bit of news, and we wanted to make sure that we share that with you. So I think with that, just wanted to share just quickly, if you haven't already, subscribe to our listserv so you can get all of our wonderful messages and announcements about our meetings. Send us topic recommendations. We're always very much open to hearing what you want to talk about, what you feel needs to be discussed as it relates to Washington healthcare facilities. As you just heard, there are success stories out there. We want to make sure we're highlighting it in the midst of all the hard work that we're doing to advance and improve Washington healthcare facilities. And then those of you who are interested, please consider, joining us next month as we start to focus on climate and climate resiliency as it relates to Washington healthcare facilities. So if you have ideas, if you have work that you've been doing, it'd be great to hear from you, but certainly that's going to be our focus. So please, again, if you haven't already connected, please get on our listserv so you can get information about how to join us. And I think our last slide is on our website. So just making sure that washingtonacf.org/COP. If you haven't already been to that site, you'll see that this is a bit of an archive of where all of our materials just sort of lays out. Again, you can connect to the listserv through this website. And this is where past sessions, all the recordings in multiple languages are posted, and you can use this as a resource. And please share this with others who are not able to join us live. They can always review our sessions, and we're going to be putting them up and putting a session like this up as soon as we can. So without further delay, I want to hand this off to Haley Elling from World Vision, who's part of our learning team, who'll give us an overview of environmental cleaning and healthcare facilities before we move on to our other guests who will be sharing about specific toolkits and strategies. So Haley, over to you.
Great. Thank you so much, Joanne. Can you hear me okay?
I can.
Great. Yes, well, hello, everyone. As Joanne said, my name is Haley Elling. I'm a WASH program manager with World Vision and part of the learning team here with the COP. I'm going to give kind of a quick overview of environmental cleaning in healthcare facilities, maybe for those on the call that are, maybe new to this topic or maybe not as familiar as some others maybe doing work in this space. Let me see if my slides want to move. Great. So environmental cleaning within a healthcare environment is really integral to ensure quality of care as a whole. When we think of environmental cleaning and specifically healthcare facilities, we know that microbial contamination of surfaces can lead to the transmission of healthcare-acquired infections, as well as to contribute to the development of antimicrobial resistance. And then in order to really understand this more, these more robust systems for routine environmental cleaning are really essential to reduce the risk of healthcare-acquired infections that patients, visitors, staff, and really anyone within the healthcare environment face. It's really an integral part of IPC, of ensuring quality of care. And in order to really to focus on this more, we need to kind of zoom in and focus on the staff responsible for cleaning. So that either that's cleaning the floors, the surfaces, those individuals, cleaning staff need to be, identified for starters. They need to be trained, provided with the necessary materials to do their job effectively. Whether that's PPE or just, the disinfectant materials, mops, and so on and so forth, to be able to effectively clean the environment and to really approach infection prevention and control within the healthcare facility. So when we talk about these individuals, we're really talking about cleaners within the healthcare facility. So, who are cleaners within the healthcare facility environment? So they're often a neglected set of workers within the healthcare facility. They have limited respect for their role. Oftentimes, they're not part of the WASH and the healthcare facility hierarchy. They usually lack formal training, whether that's training on infection prevention and control, how to clean, cleaning procedures, waste care management, and they also most often lack effective personal protective equipment and other supplies to do their job regularly. And again, as members of kind of the lowest rung of the healthcare facility hierarchy, they're often not really included or lumped together with how we think of normal healthcare facility stakeholders. So oftentimes they're, they don't really have a seat at that table. They don't have a voice to advocate for themselves within the healthcare facility system. So I'm including here just the JMP Core Indicators. We all, know and love the main components here, but for environmental cleaning practices, the basic definition that the JMP includes are really these two indicators. So asking, are cleaning protocols available, and have staff responsible for cleaning received training? So while these are great indicators that have, slowly started to measure global progress in this space, there's still so much more beyond this that we need to learn. But I will say, so here's some of the global data that's been showcased more recently. So since 2019, since 2022, we have seen, more data coverage on environmental cleaning globally, with 21 countries there having these indicators. And so we're seeing that service is rapidly growing over the course of a couple of years, but it still remains low when we're comparing it to, the other components such as water, sanitation, and hygiene that have a lot more data available, a lot more data coverage to really understand what is being done within each of these countries. I wanted to share just a couple of environmental cleaning guidelines and standards. This PowerPoint will be shared after the session today, so you can access these links if you want to, but they're also available on our WASH and healthcarefacility.org/resources page. But the first one is just is WASH Fit, which we all know and love. But then also there's this best practices for environmental cleaning and healthcare facilities in resource limited settings. We'll actually hear from Molly Patrick and the CDC a little bit later today on a specific example. There's from World Health Organization in 2016, the guidelines on core components of IPC programming in the national and acute healthcare facility level. And then of course, the 2008 Essential Environmental Standards in Healthcare. Going on to different toolkits, we'll hear really this in a lot more detail a little bit later today from our main speakers, but this toolkit was just unveiled just last year, which is a great toolkit for really implementing the best practices for environmental cleaning in healthcare facilities and resource limited settings. Really a great add-on to some other resources and guidelines that have been shared earlier. And then also just the Teach Clean package. So we actually have members from London School of Hygiene here that were involved with the Soapbox Collaborative and coming up with that Teach Clean package, who will explain that a little bit more in detail. But again, you'll be able to find those links on our resources page, and we'll also go through them as we go through the speakers today. And I just wanted to end kind of with this World Health Organization urgent challenge for the next decade. And I think Joanne mentioned it a little bit within the What Women Want World campaign, where, in the next decade, the World Health Organization announced a list of the priority urgent health challenges for the coming decade, including keeping healthcare clean. Also, what came out of the What Women Want campaign is that while they also expressed really wanting WASH as a high priority, also having clean environments was also pretty high on that list as well. So just showing that, this is definitely, we all know through COVID and everything that has happened, that emphasizing and having the importance on clean healthcare and clean quality of care is only going to become more urgent in the future. So with that, Joanne, I'll pass it back to you for, I think, a brief poll.
Yeah, that's absolutely right. Thank you so much, Haley, for just laying down the foundation before we start looking specifically at some of the toolkits and resources that you just talked about. But before we do that, we wanted to run just a quick poll of those who are with us today live. And there's really only 2 questions. We're asking you, are you currently working to improve environmental cleaning in healthcare facilities, whether that's through implementation projects, training, etc.? And then if you are you using any of the tools and resources that Haley just sort of described? And if you are not, that's fine, because perhaps today, after hearing some of our panelists, you'll at least have some resources in hand that you can begin using. So go ahead and take about 20 more seconds. I see lots of folks already starting to respond to let us know where you are with environmental cleaning efforts. Okay, we'll give another 10 seconds. I see we have folks who are still needing, yeah, there we go. More people to respond. Just let us know where you are. Okay, 3, 2, 1. If you haven't already responded, we're going to go ahead and close the poll and share some results. There we go. All right, so if we can show the results, hopefully everybody can see. Are you currently working to improve environmental cleaning? We have about, of the respondents, 75% saying yes, 13% saying either not currently working on it, but planning to, or not at all. So again, hopefully some of the resources and things that you hear about today can help in your planning, or maybe initiate some ideas in terms of how to approach environmental cleaning. So in terms of resources and tools, so we see, good bit of folks already using WashFit, 75%. The CDC implementation toolkit is already in action right now, 25%. Teach Clean is being used at 33%, and then other. So for those of you who responded other, if you don't mind helping us and placing in the chat, what other tools or toolkits, or if you even have something you'd like to share, if you can go ahead and put that in the chat, that would be really, really helpful to us, just to that we can also make some of these things available to others who are looking to do programming. So thank you for that, for those who participated. And those who did not get to participate in the poll, and you still want to let us know what you're doing in environmental cleaning, go ahead and start placing some of that in the chat. So again, we want to move to sort of our first part, our pair of presenters who are going to talk about a specific tool. And as Haley mentioned, we're going to start off with Molly Patrick, who's an environmental engineer at CDC, who's going to talk about the CDC implementation toolkit for a few moments, and then pass it on to Dr. Damilola Adeneyi, who is a program coordinator for the Center for Infection Control and Patient Safety at the University of Lagos, Nigeria, who's going to talk specifically about how the tool is being used in his context within Nigeria. So I'll go ahead and pass it over to Molly, and then we'll hear from Dr. Adeneyi.
All right. Good morning, good afternoon, everyone. Really happy to be here. So I'm just going to provide a brief introduction to our new implementation toolkit, which we developed collaboratively with ICANN and published in September of last year. This is actually our second resource on environmental cleaning that we've developed with ICANN over the past 4 to 5 years. So you can go ahead and advance this slide. So the first resource that we developed was our best practices guidance, which was published in 2019 and which Haley mentioned in her introduction. So the new toolkit is actually the implementation manual for the best practices, and it provides a structured approach for actually helping facilities implement the best practices over time. And it takes into account different types of facilities and different resource levels. I'll just describe the content of the best practices briefly, just for the purpose of describing how we structured the toolkit. So there are 3 main content chapters. Chapter 2 is about the best practices for cleaning programs. And then there are 2 more technical chapters that stem from there, one on cleaning supplies and equipment and one on procedural best practices in different types of patient care areas. But chapter 2, and I think Haley, you can just advance, just want people to focus in on chapter 2, because it's really an overarching chapter that describes a multimodal approach for implementing environmental cleaning. So a multimodal approach is a term that we use frequently in IPC to describe putting multiple strategies and multiple systems in place to enable effective and sustainable IPC practices. So we've included 5 multimodal cleaning program elements in that chapter 2, which you can see along the top, ranging from organizational elements, so focusing on administration and leadership support, to staffing and training, infrastructure and supplies, policies, protocols, and monitoring and feedback. Next slide. So the toolkit enables progressive implementation of these multimodal cleaning program elements by providing a structured process for assessing environmental cleaning programs against the defined best practices, providing an approach for prioritizing needed actions and activities to make improvements. And finally, it provides a suite of tools and resources to actually help facilities implement those improvements. The toolkit follows a 5-step cyclical process, which we know from WASH. It is what is used in WASH Fit, and it's also used in WHO's IPC implementation manuals. So this 5-step cyclical process is based on continuous quality improvement. And what it does is that it provides an opportunity for progressive and incremental improvements to be made over time through repeated application of this sort of project cycle. So we have built in 2 main levels or milestones into the toolkit to take into account different facility types and resource levels. So I think this is important because the best practices guidance has a lot of content, and we wanted to try to break it down into more manageable pieces for facilities who may just be starting to make improvements on environmental cleaning. So the first goal is to achieve what we call a basic cleaning program. And this includes all of the foundational elements in the best practices, which are needed in all healthcare facilities. The final goal is to achieve what we call an advanced program, which includes the full set of best practices. For small outpatient and primary care facilities, the basic program may be a reasonable endpoint, whereas for larger hospitals, achieving the basic program really represents sort of having the foundation upon which to continue to build over time to work towards the best practices. Next slide, please. So this diagram is a logic model type of diagram, and is just a way to illustrate how the toolkit and the best practices work together and the desired outputs and outcomes that they work towards. Starting from the left, there are some prerequisites which are recommended to ideally have in place to be able to use the toolkit. And then the 5-step toolkit process is shown, demonstrating how with repeated use, changes and improvements will be made to cleaning programs over time to hopefully result and contribute towards those longer term gains, such as improved cleanliness, improved patient and staff satisfaction, and reductions in HAIs. Next slide. For the sake of time, I won't go through this in detail, and Dami is going to take you through a real application and use of the toolkit at his hospital. But I wanted to show you the five steps as they are described. And like I said, they probably will look familiar to you with, if any of you have used WashFit, they're very similar. So you can see the 5 main steps shown, as well as some of the main activities along that first column on the left. And you can see a time frame along the top, which gives you an estimation of the amount of time it may take to go through one toolkit project cycle. So this may take a number of months, with most time being dedicated to actually making those identified program improvements. That 4th step is shown in purple, and it can take several months following completion of a structured assessment and prioritization activity to determine which gaps to address. We've also published, and I think you can just advance the slide and it'll come up. Yeah, we have also published what we call toolkit process tools. So these are resources to help facility teams with each of the recommended activities in the toolkit, and really try to make it as easy as possible to use the toolkit and work through the implementation. So for example, we have sample TORs for the toolkit project team. We have sample meeting agendas. We have really nice instructions for how to actually select a ward or unit to focus the activity on, because in a larger facility, we would suggest to really focus at that level. And then we have, we down in section C, we have very detailed information to help with prioritization and some of the recommended activities that could take place as teams are working through putting together their action plan. So a lot of really detailed content. I think we can just go to the next slide. And I just wanted to show you where you can find the implementation toolkit on. This is our sort of environmental cleaning homepage, and I'll put the link in the chat. But you can see this is our best practices homepage. And in case folks might not be aware, I actually also just want to point out at the top that we have the best practices available in 3 additional languages to English. So we have French, Spanish, and Portuguese. The toolkit at the moment is just in English, but hopefully we'll be able to work on translation. So if you can just jump ahead, I think this is the last slide. So when you click on that button, that will take you down to the toolkit resources. So these are all downloadable. I think the toolkit main instructions guide is the main document that you need, and it has links to everything else in it. But some of those process tools that I mentioned, you can also download separately on those buttons that are shown there. And there might just be one more. So all of what I'm showing on the left, these are all available online for download. Some of those templates are in Word so that they can be modified for and adapted for use. We have available a number of what we're calling program improvement tools, which are actually resources that would be helpful for facilities as they're making improvements. Things like example SOPs, example checklists. Maybe if you advance one more. Yeah, we have lots of example checklists for monitoring to help with routine and terminal cleaning, just a lot of resources that are available upon request. So as you know, if you're taking this on, just know that you can also reach out for additional resources. So I will stop there and pass it over to Dami, who's going to talk about how he helped us validate the toolkit, for which we're very grateful, and also make a lot of improvements to cleaning at his hospital. Over.
Thank you very much, Molly, for that excellent presentation. Good morning, good afternoon, and good evening, wherever you are joining from. So I'll be presenting the Lagos University Teaching Hospital Nigeria experience for implementing the CDC ICANN toolkit. Next slide, please. So this is just to give a bit of a background. We know that the toolkit was designed specifically for low and medium income countries. So Nigeria is in West Africa, like I would expect that most of us know, population of about 200 million people. The health system is structured majorly into 3 tiers: tertiary, secondary, and primary. The Lagos University Teaching Hospital is a tertiary institution and serves majorly the Lagos population with a catchment area of about 20 million people. Next slide, please. Prior to the implementation of the toolkit, or prior to the pilot of the toolkit, this just gives an overview of what the Lagos University Teaching Hospital will look like. An 800-bed tertiary facility. We have an estimate of about 25,000 admissions yearly. Like I said earlier, a catchment population of 20 million, which is about the population of Lagos. The priority ward where the toolkit was piloted was actually 2 wards, 2 neonatal wards that have a capacity of 80 beds. And the hospital has a functional IPC committee and functional IPC team. In the heat of COVID, Luth served as one of the isolation centers. And then the cleaning model within the hospital is a mix or a blend of both in-house cleaners and external cleaners. Next slide, please. So Molly spoke about the 5-step approach of the toolkit. And so I'll just speak briefly to what we did within each step. The first step was the prepare for action phase. And during prepare for action, we did basically 3 things. We identified or assembled the team, the project team. And then we carried out the risk assessment and finally identified the priority wards. In assembling the team, we had a couple of meetings of stakeholders, got ethical approvals, and the team was made up of representatives from the IPC team largely. And then we also had representatives from nursing, from engineering, and then finally from the priority ward. We agreed on the risk assessment tool as recommended by the toolkit, which was used, and the risk assessment exercise was actually facility-wide. We did a risk assessment of the entire hospital. We came up with about 19 high-risk areas, and then went on to use further criteria stipulated in the toolkit to narrow down to 2 priority wards. Specifically, we chose the neonatal wards because of the vulnerable population, and then we also had recent HAI outbreaks within those wards. And so D1 and NNU are 2 neonatal wards. Next slide, please. In conducting the baseline assessment, we assessed the 5 program elements like Molly mentioned: organization, policy and procedure, staffing and training, infrastructure and supplies, and then monitoring, feedback, and audit. Now, we identified deficits across all the elements, but we ended up focusing on a few elements, which I'll speak to shortly. The baseline assessment was a combination of a tabletop exercise and then walkthrough. And so while we did the assessment, I think we were able to do that within a few days, answering the questions as stated in the toolkit, basically answering yes or no. We found that some questions required us to actually go through the words, take a look at the sluice room, and look at the setup within those spaces. And so we combined the tabletop exercise with a walkthrough, and then we identified a number of program deficits. And then we moved on to develop an action plan. Next slide, please. We developed an action plan after we identified the following gaps. So this is just a summary of the gaps that we identified in the area of organization and policy, or policy and procedure. We realized that there was no central focal point when it came to environmental cleaning. And so the structure at the hospital is such that you have a combination of in-house cleaners and then contract cleaners or external cleaners. But there was no staff or focal person that was providing oversight to both sets of cleaners. We also observed that there was no connection whatsoever with the IPC team of the hospital, especially as regards the external company cleaners. Now, in 2021, when we started the pilot of this project, the scenario currently is a bit different from what it was. Now we have a scenario where most of the cleaners are outsourced. And so one of the things we identified was that you had a cleaning system where those that cleaned were supervised by people that really didn't know much about IPC, actually didn't know anything about infection prevention and control. And so you had the principles of cleaning used in the hospital, that were used in other institutions. I'm sure we know that the IPC standards are different from the standards of cleaning. So that's one of the things that we identified. We also realized that there was no specific policy regarding environmental cleaning within the hospital and no SOPs in that light. I already mentioned the fact that the IPC team, even though seemed to be functional, didn't have oversight, especially over the external cleaning companies. In the area of infrastructure and supplies, most of the infrastructure needed, as stated by the toolkit, were actually, available. But the area of supplies, cleaning supplies specifically, and cleaning equipment, we had some deficits in that area. And also there's some built environment challenges with respect to the kind of floors, and also the way the sluice rooms were set up. Staffing and training is one area that we focused on together with organization, policy and procedure. And like I said earlier, there was no standard training, IPC standard training for the cleaners. We also realized that a lot of the cleaners had what we would call it some form of low morale because, I think it was Haley that mentioned earlier, they are the lower rung of the ladder really when it comes to the hospital staff. And you also have, very high turnover of cleaners. And so we identified that the cleaners were not trained in IPC standard cleaning, and supervisors as well, had not received any such training. And then we also identified that there were some supervision gaps. In the area of monitoring and feedback, reporting was largely non-existent. Next slide, please. So we developed an action plan. Out of the different gaps we identified, we had to prioritize, the areas where interventions would take place. And so as recommended by the toolkit, it was a combination of looking at the recommended guidelines from the toolkit, and then what we perceived to be feasible, for implementation within the time frame. Like Molly mentioned, the time frame for implementation of the improvements, was about 3 months. And so we looked at what was feasible within that time frame and then came up with an action plan. Next slide, please. So this is just, to give a summary of the areas where we focused on the improvements that we implemented. We developed a cleaning policy, which was the first of its kind in environmental cleaning for the hospital. And then we developed SOP, standard operating procedures, for the neonatal wards. And we also developed a list of standard cleaning supplies and equipment. One of the things we identified was that some of the cleaners, the companies, and even in-house were making use of supplies that were not approved or standard. And so we had to come up with a list of standard supplies, cleaning supplies and equipment. We also developed a training curriculum and a training plan. With some, interesting findings in the area of training. Teach Clean was one of the resources that the toolkit recommended, and it was really very helpful. But the peculiarities of our context is that most of the cleaners have, low literacy levels, low educational qualifications, and then we put that together with language barrier and all of that. And so we had to use a multimodal strategy in training them. So part of what we did was that we developed a training plan to ensure that the facilitators, kept the slides, to a limit in terms of not having too many or too large slides or wordy slides, and made use of more of pictures. And then we had a lot of simulation and demonstration, which happened in the afternoon. One of the things we also did was to, develop videos, environmental cleaning videos. And so the videos, one in particular was translated in what we call Pidgin English, which is the colloquial language, which almost every Nigerian understands. And then we also executed the training using the local dialect. These are some of the modules in the training curriculum we developed. The importance of the environmental cleaning staff in IPC was a module we also included to address some of those issues in the area of esteem as far as the cleaners were concerned. And the others, PPEs, use of PPEs, hand hygiene, cleaning techniques, waste handling, monitoring, and assessment. Next slide, please. Okay, so in sustaining the impact, we had to have several meetings. I'm going to speak about some of the challenges we had in executing, implementing the toolkit. But one area was the aspect of bureaucracy in dealing with the management. And so we had to have several meetings for the policy eventually to be adopted. We also had to engage the pediatric department under which the neonatal unit is domiciled, and carry the nurses along as well. We also made donations of some basic cleaning equipment and developed monitoring checklists. Next slide, please. Okay, so I would like to speak to some of the challenges and the strategies for mitigation in the course of implementing the toolkit and some of the lessons that we learned. Next slide. During the first phase of the toolkit, which is prepare for action, a major challenge we had to do with time constraint. Now, within LMICs, as we have in Nigeria as well, we have few staff and large workloads. And so the implication of that is when you have to get people on a project to make the project team, and then the toolkit, for example, recommends that there should be dedicated time. That is not really, it's not really feasible in our setting. And so we had a challenge with time. So you have staff that already have a very high workload, and then you have to give them added responsibility. So what we did was that we had to modify some of the terms of references that we had as samples, and then we had to leverage weekends sometimes. So for example, in coming up with the policy, we had to have about 2 different retreats, Fridays and Saturdays, at a location outside of the hospital, so that people could, give extended time to what we needed to do. And then, of course, we had to leverage Zoom and all the virtual platforms to, solve the challenge of time constraint. The risk assessment tool that was recommended, like I mentioned, we had about 19 high-risk areas, and so we had to come up with other criteria to, narrow down to 2 priority wards. Next slide, please. During implementation, some of the challenges we observed include administrative bureaucracy and complexities. I mentioned earlier, even while we're preparing for action, we found that there were a lot of organizational complexities. You had cleaners that were working in silos, and there was no, central coordination. And then even when we came up with the policy, we had to have meetings upon meetings for it to be eventually, adopted. And it being adopted in principle was different from it really being adopted, on the ground. I also mentioned the challenge of low literacy level of the cleaning staff, the low morale and latent anger of some of those cleaners, and some of the logistical challenges we had to deal with in executing trainings, remembering that the issue with being on the staff also applies to the cleaners. And so in executing trainings, you have to consider their roster. So we had to deal with some of those things. As regards to organizational complexities, we had to have more meetings that would probably have been necessary to carry different groups along. And so the role of IPC champions was very key here. In dealing with the logistical challenges around training staff, we had to have series of meetings with the nursing departments who were in charge of the nursing roster. The nurses were part of the trainings that we executed because some of the nurses were involved in supervision. We had to have meetings with the different external cleaning companies. And so, to align rosters and ensure that everyone was carried along. And then we executed training in 2 batches. In dealing with the cleaning staff language barrier and the issues around esteem, like I mentioned, we had a module specifically that focused on the importance of the cleaning staff. We used videos, songs, demonstrations, and the training was conducted largely using a combination of Pidgin English, some English, and also the local dialect. And then we also realized that training the cleaners, health assistants together with the nurses, also helped to boost their morale. In addition, we ensured that we had top, management staff like the chairman, medical advisory committee, come to the trainings to actually address the cleaners, which probably, would have been the first time they would have such an encounter, all in a bid to, boost the confidence of the cleaners. Next slide, please.
Can you take 1 more minute? I know we do want to make sure we have some time for questions in the other.
Yeah, that's fine.
Okay.
Yeah, that's fine. Yeah. And so for sustainability challenges, they were linked to bureaucracy in adopting the policy. And then we also had some cleaning supply issues. And then the issue of high turnover of cleaning staff was something that we had to deal with. By the time we were done, 3 months, post pilot, we had a scenario where some of the cleaners had been moved, had actually left the system. And so we had to retrain. Next slide. What I will do now is just try to summarize the lessons we've learned. One of the major lessons was the fact that we needed IPC champions to successfully implement the toolkit. And so to deal with all the organizational complexities, bureaucracy, IPC champions were very key. In training the cleaners, we had to contextualize, the resources we had such that, we could, communicate what needed to be communicated. We used a lot of role plays and demonstrations while training. We also use local language. And then what we've done post-pilot is that we have, reduced the trainings into smaller sizes, and then we train them on the job. And so we train them on the words, groups of about 15 to 16 people, while we also assess, what they do on the job. The third point, or third lesson is that morale and motivation of cleaning staff should be a key consideration. And so what we did was that we issued certificates of competence, which for some of them was the first time they will get such certificates after they were trained. And I already spoke about the module we introduced. And finally, a collaborative team-based approach involving all cadre of staff was crucial towards sustainability. Prior to the pilot, what we had was, we had different people doing their own things, the nurses on their side and the cleaners and health assistants. But in bringing everyone together, it helped us to, at least improve the quality of environmental cleaning. Thank you very much for your time. Happy to take any questions.
Great, thank you so much. I have a number of questions that I see in the chat for this presentation and set of presentations, but I know we're running close, but I did want to throw out one question, which may be a little easier to answer. And this was for you, Demi. Are the cleaning videos publicly available? I don't know if you can comment on that.
Yes, so not publicly available like you would have maybe on YouTube, but they're actually available. And so one of the things we did was to share with the CDC team in the US, with Molly and the rest of our team. We've also had some people, some members of ICANN, for example, in South Africa and some other parts, request for the video. And so it's available. Let me say it's available on request, but not necessarily open source. Yeah.
Great, thank you so much. So again, we do need to move on to our other speakers, but I know there may be more questions on the CDC implementation toolkit and some of the information that Demi just shared with us. Please continue putting questions in the chat. We're going to try to take a lot of those, or as many as we can, at the end of the presentation. So thank you so much, Demi, and thank you so much, Molly, for helping us with this portion of the presentation. So now we're going to move on to a part 2. And we have a different pair who will be helping us in terms of understanding the Teach Clean tool. So Dr. Wendy Graham from the London School of Hygiene and Tropical Medicine, who's a professor of obstetric epidemiology, will start off by giving an introduction of the Teach Clean package. And then she'll be followed by Ms. Vachnia Tang, one of our Washington Healthcare Facilities Steering Committee members, but also from WaterAid Cambodia, who will give some example of the work that's being done in Cambodia as relates to Teach Clean. So I'll pass it to Dr. Graham, who will then pass it to Vachnia Tang. Dr. Graham, over to you.
Thank you very much, Joanne. I'm really delighted to be part of this amazing community of practice, and it really is very moving for me to hear about these developments and an excellent presentation by Demi and Molly just now. Can I just check, Joanne, do I still have 5 minutes for this? Because I don't want to steal time from my colleague. I had a plan for 5 minutes. Would that be, are we on track for that? Okay.
We're on track.
What Vachnia has to say next is much more important. Mine is by way of an introduction, and I'll just share my slides now. I think you should be seeing, I believe, can somebody just let me know if you're seeing the slide?
Not yet.
Not yet. Okay, let's go back.
There we are. It's starting to come.
Yeah.
Here we are.
Okay, right. So, yeah, as I said, a great pleasure. I can't believe how far we've come over the last decade from those early years when cleaners were so unspoken about. It's really warming to see the developments. Okay, so I'm going to do 2 things, and they're both sort of awareness raising. One is just to say a little bit more about Teach Clean, and I'm delighted to see that in the poll, many people are using it, and of course, importantly, to flag a new resource, which Joanne introduced at the beginning, which is the WHO updated resource, which takes Teach Clean and brings it right up to date into 2023. So that's what I'm going to cover. And I was also heartened to see that comment about the White Ribbon Alliance work on what do women want. And I guess as I was reflecting on preparing for this, I think it's important. We started our work as obviously in obstetrics. My interest is in the maternity area. And I think that's really important that we bear in mind. I am sure the situation around environmental cleaning is difficult in many, many wards. There is something about the maternity and the neonatal unit, which I think we sometimes forget. There are aspects of the risk and there are aspects of the 24/7 nature of maternity wards that make cleaning particularly difficult. But I'm really heartened and not surprised that women really want to see greater improvements around hygiene in the maternity. We started our work because of this increasing institutional delivery that's happening across the world. More and more women are delivering in institutions, and therefore the issue of safety and hygiene becomes even more important, and that increases as we go along. So our work started off looking at what we call safe delivery, and safe means more than cleanliness, but cleanliness is a core element. And it was quite early from this work we started a decade ago. There clearly was room for improvement. As you see, the cat on the maternity ward, and a very, very unsatisfactory situation on the bottom right-hand corner. So we were seeing real significant problems in maternity units when we did various assessments. Out of that, we had the opportunity to create something called the Soapbox Collaborative. It was set up as a small NGO linked with the London School of Hygiene and Tropical Medicine, and it ran for 7 years, and it was designed for obsolescence. And by that I mean, we set out to do a certain thing, i.e. raise awareness of the importance of hygiene at birth. And then once we had done that and perhaps created some tools as well, we would then continue to work with partners who would carry on carrying that torch. And although we carry on work at the London School of Hygiene on aspects, the Soapbox Collaborative no longer exists per se. It was designed to come to an end, and we had some fantastic partners working with us. It started, I think, again, it's really important to think of the origin of this. And we started our work in India and Bangladesh with fantastic partners on the ground, seeing real time the problem of congestion, the issue of both mother and baby, and issues of risks of healthcare associated infections. Out of that, we noticed in these congested environments, cleaning was very problematic. And we started to use microbiology. And again, as somebody who hadn't done a lot of microbiology before, I've been absolutely fascinated by showing that things that may visually look okay turn out to be at risk. What we did was microbiology around mops, and we found, and this is just an animated slide showing that we grew Staph aureus and other potential pathogens enormously out of these so-called cleaning equipments. What that made us realize is that cleaning was a very important basic component of hygiene and safety for maternity units. And we looked into what extent was already available. We found very little evidence of training, just as Dami was just mentioning. We started some work in the Gambia, and we've done work also in Tanzania, which confirmed these issues of very poor awareness of the importance of cleaners. And we started on this journey, which led us to the development of a package. It was released in 2018. We started working on it in sort of 2014, but it is a package made up of 5 main documents, a sort of overall instruction. And this is a package to train cleaners in the front line. Cleaners, and typically it works through a cascade model of having a master trainer who then trains a person who supervises cleaners in facilities, and that person then trains the cleaners. Very much focused on being something very practical, including illustrated guidelines. One of the documents is illustrations of how to clean. A core component of Teach Clean was initially 7 modules. Hand hygiene, you can see the 7 here, and then we added others as we learned from experiences in country, the importance of supportive supervision, the importance of locating Teach Clean in a broader continuous quality improvement process. We also carried on formative research, just one example of a quote showing you how important the morale of cleaners is. They do a fantastic job. Of course, along came COVID and has also reminded us the importance of these frontline workers. But also this quote shows you that sometimes the healthcare professionals didn't realize how important the cleaners were. Anyway, many moments, and many of the colleagues on this call were part of an interesting moment when we tried to raise awareness of cleaning, including the presentation to the Director General of WHO of the Golden Mop, which happened in a wonderful photo opportunity moment. really emphasizing back to basics. I mean, we have a lot of technology needed and a lot of advancement needed in our clinical areas, but actually back to basics is also very key. The important thing to end on before I pass to my wonderful career and my colleague from Cambodia is that WHO asked us, I think initially in 2019, if that we would be happy to turn over Teach Clean as a basic resource that could be used and updated and made available as a WHO document. There are many people on this call that have been part of that, and Claire Kilpatrick in particular, I know is online. This was just released earlier this month, I think the 7th of March, it was finally released. Here are the links. This again, it builds on Teach Clean, it updates it. And the purpose of the package, it has the WHO package has these a focus on the trainers and then a set of resources. It's very practically focused, it's very digestible. I do hope that in the first document, the training guide, it really helps you understand about the importance of your audience for training, the type of materials, just as Dami was saying, you have to recognize that our cleaners are not always literate. And in the second document, which is the resources, they have got 8 modules, so they built on Teach Clean, and they have a very practical way of presenting it so that people can really build on it and use it, contextualize it. So as I said, our work continues. In fact, we're carrying on work with WHO to develop a curricula for the master trainers who can then take the WHO document and make it available. We're doing this work with Cambodia, which you'll hear of next, with WaterAid, but other work. So although Soapbox has ended, our passion for all things clean, and I do really want to echo, I really worry. I remember one graph many years ago showing you that some of the problems were more acute on the labour ward. I really hope that disadvantage of the maternity ward has been addressed. It is a 24/7 area. It has very specific issues of healthcare associated infections. And frankly, we are failing women cleaners and healthcare professionals if we don't ensure clean, safe birth and a good hygienic environment for delivery. So I'll stop there because the real important person who's going to present is my colleague from Cambodia. And just a final word of thanks for all of those that I've had a chance to work with on this interesting journey to clean, safe birth. Thank you.
Thank you so much, Dr. Graham Vachna. If you can hear us, you can go ahead.
Yes. Thank you, Joanne. Can you allow me to be co-host? Oh, can I control my own slide? I mean, like, can I control my own slide and then share from my laptop?
Sure. I think, Haley, we can give permission to Vachna.
One moment. All right, Vachna, you should be able to share your screen.
Thank you. Here, thank you, Dr. Wendy. Very impressive. Like, congratulations for. I mean, like, we have like Teach Clean WHO released recently. So congratulations to all your work, so collaboration, London School team. So good evening from Cambodia. So my name is. I'm glad that I have the opportunities to present and share our lesson relating to environmental cleaning in healthcare facility. So before I start the sharing, let me introduce myself. My name is Wendy. I'm from WaterAid Cambodia, and I'm coordinating all activities in Clean Frontline project in Cambodia. So before we start this project, we did a need assessment on this. I mean, like the need assessment, and then we found that there is trainings relating to IPC, but it's not specified on environmental cleaning. So another areas that we found that there is no comprehensive document on environmental cleaning in Cambodia. And one thing that cleaner has been very knowledgeable during the COVID-19 events in Cambodia. Yes, they are the frontline workers to the IPC, but they have never received any formal trainings, even in Cambodia, and that's why in Cambodia we conduct the Clean Frontline project. So Clean Frontline projects in Cambodia will be the first project that provide trainings to cleaner in healthcare facility, and it also the first project that contextual tech clean. We also use the draft of the WHO tech cleans and incorporate with the Cambodia infection prevention and control guideline to make our contextual tech clean adapt to our local guidelines. So because of cleaners is mainly illiterate, so we use learnings, adult learning and participatory approach. And we also use the training materials and educational video as well. So our project has been piloted to 13 referral hospitals in 3 provinces in Cambodia, and we focus on referral hospital here because only referral hospital in Cambodia have cleaner. So for the lower level health centers, they don't have health center. That's why we pilot on the referral hospital first. So the project is a partnership between the Ministry of Health, National Institute of Public Health, London School of Tropical Medicine and Hygiene, and WaterAid. Ministry of Health and NIBH is the provide technical support in the project, while London School provide technical support relating to tech clean, and WaterAid coordinates all activity in the project. This is the project key deliverables and activity. First, we did need assessment, situational analysis in order to collect the data and to adapt to contextualize the tech clean, make sure that it adapt into our context, and make sure that we can use it, incorporate with our digital approach. And then we contextualize it, develop the material, training materials by WaterAid together with partner. And then we provide training of trainer and supportive supervision is the last step. And this is the process evaluation. We use it to measure the effectiveness of clean training. And one thing about Clean Frontline is we have the impact evaluation, which use the microbiological cleanliness to measure the cleanliness of the cleaner after receive the intervention, whether they improve the cleanliness of the hospital or not. So we have that as well, and this under the technical support from the LSATMs. So let's move to the contextualized process. So we have selected the Departments of Hospital Services as our master trainer. They are from the Ministry of Health. The reasons that we choose them because they are the experts of IPC. They work on quality improvement programs in the country. So they are the most fit to be our master trainers in the country, in the project. So after we select them to be our master trainer, they have involved in the projects in the beginning. They involved in the need assessments, and then they get the result. They know the context. They use the policy guidelines in order to contextual the tech clean with all stakeholders. They receive training orientation about tech clean from Dr. Wendy, and then we come to the discussion just like master trainer like Bernard from WaterAid Australia, Georgia, came to Cambodia to support us all together to ensure the talent, develop the lesson plan curriculums together. So we come up with the training manual, and then after that we identify what is the items in the clean box. So the clean box is referring to a training material and also the cleaning materials that we will provide to champions. Champion here refers to the one who received training from master trainer, and then we give them, and then we develop the digital video to share in the training. Moving to the intervention implementation, our training approach is training of trainer. We divide into 4 training and trainer, ensures that 8 participants. The training of trainer here, the training scope is very small. Make sure that the training is very small. So 8 participants have a chance to participate actively in the training. So we divide into 4 training, and there are 52 champions were invited to join 4 training of trainer. So around
Virginia, if you can hear us. I think she's frozen. Give her another minute or so. Looks like we've lost Vachnia's signal. Let's see if she's able to come back. Oh, wait, I think she's still there. Hold on. I think we did lose her. Let's give her just a minute to see if she can log back in. She just has a few more slides.
Joanne, if Vashni is not able to join us, I wonder whether Georgia, who's on the line, we saw an earlier version of Vashni's slides. Do you have a?
I've actually got the complete slides here, so I'm happy to.
Oh, Vachnia is back.
Okay,
she's back.
I think she's back. There we
hello,
go.
I'm back.
Hi, Vachnia.
Sorry.
If you turn your,
Yeah,
if you turn your video, maybe turn your video off. That
connection
can help.
here. Yeah. I can turn off the video and then share the
Yes.
screen
There you go.
again. Yep.
Okay.
Yes.
It's almost there.
Oh. Yes, here.
We can also share your videos from this side, Vachnia, if that's helpful.
Yes, I'm there. Yeah. So
We don't yet have, oh, we have your desktop.
Yep, sure. Oh, so do you see my slide right now?
They're coming back slowly. Would you like us to share from our side?
Because I have the update slide from my side.
Okay.
Yeah. But do you see my slide right now?
Yes, they're back.
Oh, okay. Yep. So let me continue. So I think I'm talking about the criteria for choosing the champion right now. So we choose the champion based on their experience on supervising cleaner at hair care facility, and they are also involved in cleaning activity. Second, they have a high commitment in order to get knowledge from the master trainer and shares to people at hair care facility, especially the cleaner. And third, they be able to read and write, and they can use the smart tablet or smartphone. So they don't have to be hair care staff. They could be the cleaner who could be able to read and write as well. So some champion are the cleaner at the hair care facility as well. So they provide training at hair care facility, and then here is the result that we provided to them. We provide the contextual training manual to them. The green one is our contextualized training manual. In the training manual, it's composed of the slide presentation, lesson plan, supportive supervision documents, and even like the checklist, even the competency checklist even in that document. So the result, we have produced a video of cleaning video procedure we send the videos to them as well to make them share during the training at healthcare facility. And the video, it has been delayed for the initial training because the process of creating video is a little take times a little bit as we have expected. So for the first and second TOT, we could not be able to send the video to show the video during training, but by the third TOT and the fourth TOT, we could be able to share and then share the video during training, and then champion use the video at the training during training at healthcare facility. So the same illustrated guideline was based on the video of the cleaning procedure. So it has been delayed as well, but we are now working on it to finalize it. But the video has been finalized, and we received a good comment from both champions and cleaner, even the master trainer. They say that it's good for cleaners to understand very quick. Clean box has been sent to the champion after they receive training. So there are a training material, also the cleaning material. After the cleaner receive training from champions, they receive some cleaning material from the champion as well. The monitoring and supervision items is also sent to the champions. So after the training at healthcare facility, the champion have the role to support the cleaner to create cleaning schedule, new cleaning schedule that emphasize on high touch surface and low touch surface together, and also the patient zone area as well. Make sure that they could be able to create the plans for them daily to cleanse the areas for them. However, the cleaning schedule here might be a little bit far from what we planned. Using competency checklists and fluorescent and gels and using touch is also used by the master of champions after they provide trainings to the cleaner. As you can see in the picture, the champion use the competency checklist to check whether the cleaner use the correct procedure to clean, or the fluorescent and gel UV touch here to check whether the cleaner cleans it very clean, or it's still partially still has something like the part of the gel, the place that the champion put on it. So for the master trainer has the role to provide field supervision. So in our project, they went to have a to provide supportive supervision to check that, and they support champion to deal with the current challenge that they are facing. We also create the Telegram communication between champions and master trainer. In order, it is a platform for champion to connect with the master trainer whether they have any problems, so they can connect through that Telegram platform. For the key lesson one, we have documented many key lesson learned, as just like Dami from Nigeria has shared. It's very good experience. For us, it's same but different context here. We identify that collaboration with the strategic national partner is very important for our project. We have been partnered with Ministry of Health, National Institute of Public Health, so it links our projects to influence at the policy level more easier than working with them. Complement national IPC policy and voice guideline is very important as well. We ensure that as is a common practice, health center level. If we don't complement with the national guideline, we're afraid that we create a we create another substitution procedure for healthcare workers. Champions are very important. We are not like their leadership. They are not. They are the one who share the things to the people at healthcare facility, especially cleaner. So if they have experience or training, to create a good quality of training at healthcare facility. If not, like in our observation, some junior champions, they don't have experience on training, so they face a challenge in provide training at healthcare facility. Overall results are very important. They measure.
Oh no, I think we've lost Vachni again. So she was just on her last few lessons learned points about the audiovisual resources. And so I don't know if anyone wants to assist in wrapping up, if anyone.
Hey, Bernice, would you like to go ahead,
Yeah.
or otherwise I can say a couple of points as you wish?
You go for it, Georgia.
Okay, well, please, interject if there's anything I'm missing. But hello, everybody. I've got a few slides next, but just in terms of finalizing, I think it's been an incredible project, and I think what really came through is the national partners collaborations and how much that made a huge difference in the contextualization piece. That was incredible. I think going forward, one of the issues that we encountered was how difficult it was to actually make sure that the routine daily cleaning was happening effectively with really limited resources. And I'm not just talking about infrastructure and equipment. I'm talking about human resources. Very few cleaners, very difficult, lots of difficulties in task shifting and so on. And I think this is something that the Cambodia government is now thinking about, because they're thinking about national rollout. And they're thinking, how can we turn this around? We've trained cleaners, they know what to do, they're committed, but how can they be enabled to routinely clean when we have so few of them? And I think that's something that needs to be taken forward, and it's not going to be easy. It's definitely a challenge ahead. Bernice, please, would you like to say anything?
Just to highlight that, I guess the next steps are hoping to get the manual and the training materials endorsed by the Ministry of Health. And as you mentioned, the scale up to other provinces is something that the Ministry of Health is really keen to see of this resource. And hopefully that will be a national scale up. And also looking to do some sort of life cycle cost analysis on environmental cleaning at the referral hospital level to support some of the ongoing requirement around, the cleaning supplies and materials required to maintain and sustain good environmental hygiene in the referral hospital level.
Oh, great.
That's
Thank
it.
you. Thank you so much, Bernice. We are so
Thanks,
very
Vanessa.
grateful. Oh, bitch, there you are.
Thank Wendy and Joy. Just apologize for my internet connection. I don't think that it was that bad today. Yeah.
Well, you did really great. You have a lot of good compliments in the chat, and your colleagues, both Georgia Gan and Bernice Sarpong, were able to finish out your final lessons learned. So we do thank all of you for pulling together. We thank all of our speakers, Dr. Graham. We're inviting now all of our speakers to be ready, because we want to open up a question and answer period here. So Molly and Demi to come back online. And again, thank you all so much for coming and sharing your work. I know we have at least one question in the chat, but I do want to encourage you, if you have a question, go ahead and raise your hand on the Zoom, or go ahead and start putting in your questions in the chat. We do have a few moments before we wrap up to try to respond. And so I see that Evelyn, if Evelyn is still here, had a specific question for Demi and Molly about what plans have the healthcare facilities put in place to address the cleaning supplies challenge. So I'll just give that to you both.
I'll let Dami go ahead and answer that.
Okay, so the issue with cleaning supplies has been a perennial issue, almost an eternal issue in this part of the world. And so one of the challenges we encountered at the beginning, even when we came up with the action plan, was accessing what the budget really was. First, there was no dedicated budget for environmental cleaning. And so, to have some sense of what is budgeted for that purpose. It became a bit more complex when a larger chunk of cleaning was outsourced, to external cleaning companies. And even though I don't have the details of the MOU, at least I know that the cleaning companies are responsible for purchases of cleaning supplies. And so it's not directly from the hospital, at least, a sizable part. The hospital is still responsible for some of the purchases, that apply across board. And so what we did was, and also bearing in mind that increasing the budget for cleaning is not going to happen. The general budget in this part of the, we know, it's been a perennial issue. So what we did was we tried to, move things around. And so this is one area where training can solve some resource problems. So for example, we discovered that some of the things that were purchased were not necessary. Some cleaning products were actually not standard. And so why waste money on purchasing, cleaning products that are not useful, that are not IPC standard? That's one. Two, we also discovered that training on the basics of environmental cleaning, such as you do not disinfect without cleaning first, solves a lot of problems. And so what we had, before was when people want to clean, maybe there's a spill or something, they add detergent and then they add, here, what is commonly used, the brand name is JIC, which is basically sodium hypochlorite. And so they mix all of that together, to clean, and then they use more disinfectant. And so explaining to them that the presence of organic tissue, all right, inactivates the disinfectants. And so there's no point using disinfectants if you've not cleaned. So clean initially, and then you can use the disinfectant. Also, helps us to save some money, some money in that regard. And so the way we've been able to solve, the problem to an extent, because the problem still exists, is that we've been able to, plug some of the wastages that have occurred, by virtue of not being properly trained or, purchasing cleaning, supplies that are not really necessary. Finally, I'll add, while rounding up the first cycle of the project, the pilot itself, we actually, donated some, cleaning equipment, basic things like the 3-bucket system. And 2 years after, because we've started another round of training, those 3-bucket systems are still in use. And so it's really helped. Of course, while we train them, we also train them with your regular bucket of water, multiple buckets, because we know there are parts within the hospital where they don't have those 3-bucket systems. And so providing a few cleaning equipment in course of the training has also helped to, reduce the burden of the problem. So I hope that answers your question.
Great. Thank you so much, Demi. If there are no other questions, again, if you're still thinking as you're absorbing all the great information that you have been receiving through the presentation, that's fine. If you think of something, just go ahead and place in the chat. But I did want to pivot just slightly and invite Dr. Georgia Gahn from London School to talk a bit about a clean workshop that was held, I believe, last summer in 2022, where there was some discussion around research and environmental cleaning, and just give us a bit of a view of some of your discussions and how this really helps us in thinking about next steps. So I'm just going to open it up to Dr. Gahn, and then I see Mariella, your hand up. We'll get over to your question if we have some more time. So pass it to you, Dr. Gahn.
Thank you, Joanne. Can you see my slides?
I can.
Fantastic. Okay, so, well, thank you so much for inviting me today. And as Professor Wendy Graham sort of mentioned, I think it's really exciting. I remember starting to work on this topic in 2014, and I think it's really exciting how much there is out there now and how many people are interested in the topic and how much things have gone forward. Yeah, so basically what I've been interested throughout is making sure that we collate evidence-based lessons around environmental cleaning. First, it started with needs assessment, and now it's moving into implementation research and thoroughly conducted trials around this topic. And I think this is really important because we all know that in resource-limited settings, we have limited resources to play with. So we're all very interested to understand what works, how, and how can we contextualize it to our environment that we're interested in. And this is why initially with our group, starting about 1.5 years ago, we started to look at the evidence around implementation research on environmental cleaning programs. And what we realized, even though there was quite a few systematic reviews out there looking at the link between healthcare associated infections and environmental cleaning, there was extremely little around intervention programs in resource limited settings. And we also conducted our systematic review, and we found very few thorough studies, poor reporting quality, limited studies from low resource settings. So even if there was a low income country interested in this that conducted a pilot, often was a very well equipped hospital. Often they were not using standard outcome definitions of cleanliness. And in general, we found very low cleanliness levels reported from the few studies that we found. And again, very poor descriptions such as the wash infrastructure. So now, having been faced with that, knowing that there are systematic reviews and they tell us very little, we kind of came to the conclusion that even though there are some promising intervention out there, even in the literature, we need more primary research to ensure that we can use the resources as well as we can and in a cost-effective way, especially in terms of scaling up. We've conducted several studies in Eastern Africa, Western Africa with Teach Clean, but with Cambodia, for example, was the first time where we took it up to 13 referral hospitals, and that provides different. So this is where we came together with an incredible stakeholder, and I wanted to show you these pictures to do cleaning together, and this kind of made me think of how, as a community of practice here, we're kind of bound to have to work together on this to make sure we strive to build the evidence base as far as we can. So this stakeholders group kind of came together, and the purpose of this group and this workshop that Joanna mentioned that kind of was held last June was to kind of identify the research needed to enhance the implementation of best practices around surface and on critical equipment cleaning in healthcare facilities with a specific focus on resource limited settings. And this was a partnership between different stakeholders and different institutions. And the idea was to start from these evidence gaps and say, what do we still want to know, which will take us forward in terms of implementation research in environmental cleaning. And what came out was an incredible group of people with representatives from almost all continents. And we gathered together people with expertise in infection prevention control, hospital cleaning, disinfection, wash, health policy, implementation science, with a focus on environmental cleaning and resource limited settings. And ultimately, we wanted to create a set of priority areas that funders would feel confident they should invest in, and policymakers should really enable to support this research that we would highlight. And we would hope that also advocates and international organizations would really promote the need to fill these research gaps. So we did this research prioritization workshop where we came up with 12 priority research questions. This is not for you to read. I'm going to highlight some of them, but I just wanted to show you that essentially we have 12 priority questions that we think are really going to take the field of implementation research forwards and provide us with evidence that allow us to put together environmental cleaning programs that are cost effective. And I just wanted to show you some example questions that we came up with.
So just one more minute. Okay.
Yes, one is around standards. For example, how many cleaners do we need? Given a certain type of facility, number of patients, type of rooms. We don't know the level of staffing that we need to ensure daily cleaning, for example, patient zone, which is one of the priority. There are some questions at the system level. So for example, what system level factors can support the professionalization of cleaners? We all heard how cleaners are neglected cadres of staff, untrained, often they have different types of contracts than other healthcare workers. We know that there are some key questions around behavior change. For example, what can sustain cleaning behaviors, maintaining frequency and quality in the long run. And also there are some questions around innovation. For example, do we need detergent alone, or do we definitely need disinfectants for low touch surfaces, which can really help us make things more cost effective in the long run. I also want to highlight, I'm not going to go through all of them, that the policy brief, or sort of the briefing, because it's called the clean briefing, that we kind of put together during this workshop, and it's going to be released very soon, and I can share with you, also talks about overarching consideration to think about when you're conducting implementation research in environmental cleaning. And I'm just going to go over a couple of them. One is accountability. We all know that if we want environmental cleaning to happen as a program in a hospital or several hospitals, we need to make sure everybody in that hospital is on board. And there needs to be accountability and transparency on environmental cleaning programs. And again, we talked about several of the presentation highlighted the status of cleaning staff. Often are women, often come from low socioeconomic backgrounds that have low literacy profiles. And this is really important when you're trying to implement an environmental cleaning program. And this document talks about other overarching considerations that I'm not going to discuss today in the interest of time. But I just really hope this briefing will be with you really soon, and we can really advocate funders, policymakers and advocates to really try and invest in this really essential research. Of course, there was an amazing organizing committee behind this with Angela Dromowski, Emilio Hornsey, Wendy, Claire, who's also here, NASA, and a bunch of incredible signatories that really are behind these 12 research priority questions. So I hope this will be useful to sort of bring the field forwards. Thank you.
Great. Thank you so much, Dr. Ghani. You just got it in. We thank you all so much for hanging in there with us in this session. I believe we all have learned so much and had such opportunity to hear from great speakers in terms of the work that they're doing, and the context, the application within different contexts has been so important for us. I know that we are over time by 2 minutes, and I know I see, Dami, your hand is up. Okay, so I know there might be some closing comments, but I want to just again thank all of our speakers, thank all of you all for again spending your time here. If our speakers would allow us, could we extend by just 1 or 2 minutes, maybe to at least address Mariella's question, and then Dami, I see your hands raised. You want to make a final comment. If those of you who need to leave, we understand, but if you can hang on with us for another 2 or 3 minutes, that would be great. Mariella, would you like to unmute yourself and ask your question?
Can I say one word? This is Dr. Arvind Fukon from USA, Arizona. Arvind Fukon.
Okay. Dr. Fukon, do you mind waiting if Mariella, if you're still there, if we can have Mariella go first, and then we'll come back to you.
Okay.
Okay. Mariella? We have no sound, Mariella. No sound. Oh, I'm sorry, Mariella, we can't hear you. If you can maybe place your question in the chat, that could be helpful to us. We encourage you to use the chat, Mariella. Dami, would you like to make your final comment?
Yes, Dr. Gorn, thanks for the presentation. So I'm quite interested in your 12 research questions that you raised. I know you said it's not for us to read, but if it's possible to get that, because I also noticed that we don't have many publications in this area, and we're also working together with Molly and exceptional team on a few publications. But for future references, I think that would be helpful. And also wanted to appreciate Dr. Wendy. Thank you for your presentation. Particularly the Teach Clean resource is a fantastic resource. It was very helpful in the course of coming up with our curriculum. Thank you, everyone.
Thank you, Dami. And Dr. Fukon.
Yes, thank you. It is an excellent presentation. I represent WASHRAG, Water Sanitation Hygiene Rotary Action Group. I've been working around the world in the 4 villages. You are doing the healthcare on the facilities, but you have to be careful about the clean, safe water, hygiene aspects in your hospital and everywhere. You know, that's my main point, because many villages, there's no even water. I have to get check dams and put, some people even can't pump, no electricity. I have to use solar pump, solar energy, like that. So depending on the environmental situation, you have to plan your cleanliness, and it is a vital. And I think I like your approach, the champions, and training them what to be done. Exactly. You have to specially check where your healthcare are located. So you have to initially we call community need assessment. You have to do that. Make sure that you have clean, safe water, because without clean, safe water, you can't save anybody. Because if you contaminated water, your death rate will increase and all. Thank you very much. It's an excellent presentation.
Thank you for your comments, Dr. Bakan. And again, thank you all for your patience. We will officially close, and again, see you next time as we talk about WASH in healthcare facilities and climate resiliency. Thank you so much. Have a great rest of your evening, afternoon, and some of you, your morning, and we will see you again. Bye-bye.
Yeah, thank you. Bye-bye.
Bye-bye.
Bye.